ये किसी का साउंड आ रहा है मुझे लगता है. Can we go live, Dinesh? Okay. So good evening, everyone. Good evening, everyone. We are here with another very interesting webinar of UP State Ophthalmic Society. I welcome you all in this webinar series, which which we held monthly. And today we are very fortunate that the stalwart speaker and renowned glaucoma surgeon across the world, Dr. Tanuj Dada sir, is here to tell us about the latest development in glaucoma surgery, which is microinvasive glaucoma surgery. Sir, we are so thankful to you for your precious time and for accepting our invite of UPSOS. And along with that, we have mentor and mentor series where 3 case presentations will be done. And they are very nicely mentored by Dr. Geeta Behra from Pondicherry, Dr. Devang from RP Center Ames, and of course, Dr. SP Singh sir from Allahabad. With this, we have wonderful chairpersons to share the today's experience and knowledge with us. We have Professor Abjeet Madam from KGMU, then Dr. Manoj Saxena sir from Aligarh, Dr. Shama from Prayagraj, and Dr. Tirupati Nath from Agra. So with this, I will hand over the mic to, okay, now I can see Dr. Shashank sir, President of UPSOS, who has joined, under whose guidance all these programs of UPSOS are being conducted. So I welcome Dr. Shashank sir, and I will request him to say a few words.
हेलो.
हाँ, थैंक यू सर. नमस्कार सर. नमस्कार.
हाँ, नमस्कार डॉक्टर एसपी सिंह.
हाँ.
जी.
थैंक यू डॉक्टर सालवी फॉर अरेंजिंग दिस वेबिनार. एंड मुझे बड़ी खुशी हो रही है कि हर महीने बिल्कुल
नहीं,
खास
थैंक यू
जो
सो
हमारा
मच.
संशय होता है उसमें डॉक्टर सालवी बिल्कुल रेगुलर एक वेबिनार के साथ में आ रही है और हर
नहीं,
बार
बहुत
ही
अच्छा. आई लाइक टू कांग्रेचुलेट एवरीबॉडी फॉर रनिंग सच वंडरफुल academic discussion, academic talk, and this should continue.
Thank you, sir.
डॉक्टर
Thank
सालवी.
you.
Good afternoon to everyone of you. I joined little bit late because एक आने वो जस्टिस आ गए थे 2 मिनट के लिए, तो
जी
उनको
सर.
छोड़ने चला गया था. जी. हाँ
जी
हाँ.
सर. Yes.
हाँ डॉक्टर सालवी, पहले तो आपको इस जो हर महीने जो आप अरेंज कर रही हैं और अच्छे टॉपिक और अच्छे स्पीकर्स के साथ आप आ रही हैं, तो
हाँ.
ये हमारी यूपीएसएस के लिए बहुत बड़ी उपलब्धि है और
Thank
इसके
you,
लिए हम
sir.
आपको बधाई देते हैं. और
Thank you,
हमारे
sir.
जो भी हमारे चेयरपर्सन डॉक्टर अजीत कौर, डॉक्टर मनोज सक्सेना, डॉक्टर श्यामा द्विवेदी, डॉक्टर तिरुपति नाथ, ये एमिनेंट ऑप्थेल्मोलॉजिस्ट ऑफ द स्टेट, इन सभी का स्वागत है. डॉक्टर वाही, डॉक्टर रुचिका, वो आर मॉडरेटर हियर, आप लोग का भी वेलकम है. एंड प्रोफेसर एसपी सिंह साहब, जो कि वेबिनार के लिए हमेशा टाइम देते हैं और अपनी नॉलेज से हम लोगों का ज्ञानवर्धन करते हैं, उसके लिए सर आपका बहुत बहुत धन्यवाद है. और डॉक्टर बेहरा फ्रॉम जिपमेर एंड डॉक्टर दिवांग एंड गमो फ्रॉम न्यू दिल्ली एम्स, आप लोग का भी वेलकम है. नाउ डॉक्टर शालिनी
Yes, sir.
एंड डॉक्टर तनुज दादा, क्योंकि आज हम कीनोट इस पे है MIGS पे, दैट विल वेरी यूजफुल एंड बेनिफिशियल फॉर द members. So Dr. Salini, please continue.
Yes, sir. Yes, sir. Thank you, sir. Thank you so much. And we have wonderful moderators of today's program. Dr. Ruchika Agrawal, she is head of the department and professor in Rama Medical College at Kanpur. And very bright, she was my student, now she has become professor and head, and I feel so proud of her. And of course, we have Dr. Jatinder Wahi, who is a very prominent ophthalmologist from Lucknow. Both of them will be conducting the session. And I will request Dr. Ruchika and Dr. Wahi to please continue.
Thank you, ma'am. Thank you so much, ma'am. So I welcome you all once again on me, Dr. Ruchika Agrawal and Dr. Jatinder Vai will be moderating the session. So just a brief introduction to the chairperson. First is we have Dr. Professor Abhijit Kaur, a distinguished ophthalmologist, academician, and an administrator too. And we are aware of her specialty in oculoplasty orbital disorders. And we are honored to have you, ma'am, here. We welcome you. Then we have Dr. Manoj Saxena from Aligarh, UP. He's a renowned ophthalmologist and he's a director of Prakash Netralaya Retina Foundation. With more than 30 years of experience in retina, cataract, and refractive surgery, he has made a significant contribution in ophthalmic care. We welcome you, sir. Then we have Dr. Professor Shama Divedi from Regional Institute of Ophthalmology, Prayagraj, UP. She's an accomplished teacher and researcher and a great clinician as well. We welcome you, ma'am. And then last but not the least, Dr. Professor Tirupati Nath from SN Medical College, Agra, UP. He's an ex-fellow of Shankar Netralaya and a renowned glaucoma and anterior segment specialist. So with this galaxy of our chairperson, we proceed to introduce our keynote speaker, and in fact, who needs no introduction. We are honored and privileged to have Dr. Tanuj Dada with us. He's an internationally acclaimed glaucoma specialist, academician, and researcher with extensive glaucoma. His expertise in glaucoma, cataract surgery, neuroprotection, and ophthalmic imaging. He has authored more than 350 scientific publications and numerous book chapters. I think he's a sought after speaker in national and international conference. So we are fortunate to have sir with us. So without much delay, I invite Dr. Tanuj Dada, sir, to please proceed and give his talk. Sir, your slides are visible.
Sir, we are not able to hear you.
Able to hear you. Your slides are visible, but I think sir is not speaking something or.
Yes, now is it visible?
Yes, sir.
Yes,
you
sir.
are-
Yes.
So, good evening, everyone. I thank the UP Ophthalmic Society for this kind invitation, and especially Dr. Shalini Mohan, whom I remember as one of the most outstanding senior residents we ever had in RP Center. And I'm so happy to see that she has gone from strength to strength and now member of the scientific committee of AIOS and heading the scientific committee of UP. So all the best to you, Shalini, for many more accolades in your career.
Thank you so much, sir. All your blessings and inspiration.
So today's talk is to clarify some truths and myths about a very popular glaucoma surgery that is known as minimally invasive glaucoma surgery or micro-invasive glaucoma surgery. So this is the talk of the town, and anybody who is following a career in glaucoma or cataract surgery must know about MIGS. So basically, MIGS is an ab interno surgery which is self-sealing. It has minimal trauma, and why it is popular is because it has got a very high safety profile and a rapid recovery for the patient. So basically, in this surgery, you make an ab interno incision and operate on the trabecular meshwork. So you have standalone MIGS. Usually, it is combined with cataract surgery. And now there is another term coming up, what is known as combination MIGS. So here you combine two MIGS procedures, most commonly dilating the Schellem's canal and stenting the canal, or you incise the canal and also do endoscopic cyclophotocoagulation. So you're combining two MIGA procedures. Now, in recent advancements, combination MIGS also you are combining surgical therapy with medical therapy, and these are very recent advances. So this is known as the spyglass IOL system. So here you have drug-eluting pads which release bimatoprost. And the second one is the eye stand, which has got a travoprost. So these are both surgical technologies where you're also having a sustained release, and up to 3 years, in studies they have been shown to reduce the intraocular pressure. Whenever you start the journey of MIGS, you must learn how to do intraoperative gonioscopy. So you have to learn to visualize the angle structures under the surgical microscope. So here we are going to perform goniotomy in a patient of primary congenital glaucoma. So you can see there is an anterior insertion of the iris and this is a featureless angle. So without identifying the angle structures, do not proceed with any MIGS procedure because you can do more harm by causing injury to the adjacent structure. And this is one shortcut. Those of you who don't have a gonioscope as yet, in tomorrow's OT, what you can do is just shift the head of the patient and put in some BSS or normal saline. So just by tilting the eye, pulling this with BSS, you can see this is the view what you get from the gonioscope. But if you don't have a gonioscope, then you can just use the water meniscus and you will be able to see the angle. So this is now view of the angle without use of gonioscope. So this you can start to see the angle structures. So here I'm doing a gonioscopic assisted trabeculotomy without the gonioscope just by using water as a meniscus. So it will undo the total internal reflection. So for beginners, you can just start viewing the angle structures by pulling water and tilting the eye and you will be able to see the angle structures. So that is a good way to familiarize yourself with the anterior chamber angle anatomy. Now, there are several kind of MIGAs, but I'm going to focus mainly on the actual MIGAs of the trabecular meshwork. So there are 4 types. One is trabecular stenting, where we have iStent and Hydrus both available in India. The second one is trabecular cutting, where you can use 26K needle bang, KDB or a micro hook or a suture. The third one is only trabecular dilating. This is ab internal canaloplasty. And now combination MIGS is getting very popular where you dilate and also cut the canal. So there are several new technologies which can do this. And there is one very exciting advance in MIGS which is going to come soon to Asia. And this is like flying aeroplane without the pilot. And here you don't need much surgical expertise in operating the TM. So this is known as the flight system. This is femtosecond laser image guided high precision trabeculotomy. So here you have a proprietary software you can focus the gonioscopy on the screen. So you have a large view of the angle structures and there is a OCT system. It will lock the laser onto the trabecular meshwork. So you make a 500 micron incision in the trabecular meshwork. So it will focus and you just have to fire one button and it will make a punched out hole in the trabecular meshwork. So this is a very innovative technology because you don't require the patient to be in a sterile environment and you have a precise cut in the trabecular meshwork. So this is a very new recent advance which is going to change the way MIGS is going to be projected in the future. Now coming to technologies which dilate and cut the canal. So this is the VR 360-degree system. So here you have a catheter that is injected into the trabecular meshwork and it has pores to release viscoelastic. So in the stage 1, it will dilate the entire canal. And then in stage 2, you can also cut the canal. So it is a viscoelastic dilation as well as cutting the canal or putting intermittent holes in the canal. So here you can see dilating and cutting the canal. And this is the streamline system where you make 150 microns holes in the canal and adjacent area you inject viscoelastic. So it is good to expand the canal to restore function and then you also cut the canal and that reduces the bleeding and also protects the outer wall of the canal, which is very important if you want to prevent fibrosis in the post-operative period. Now coming to the most popular MIGS procedure, that is the iStent. So there are 4 generations of iStent. The iStent 1, which was single device, and iStent Inject 2 devices. Now you have iStent W, and the 4th one is iStent Infinite, where you have 3 devices put in the eye. So this is basically a trabecular bypass where you inject these stents into trabecular meshwork and it bypasses the obstruction in the TM to facilitate aqueous outflow. So the principle is very simple. You inject this into the TM and it will allow the aqueous to go through any obstruction and deliver it to the Schlemm's canal to increase aqueous outflow. Now, this was a very important study known as the COMPARE trial, which compared the hydrous versus iStent in patients of primary open-angle glaucoma after they were washed out of medication. Now, remember, in any glaucoma patient, you require target IOP of at least less than 18 if the patient has got mild glaucoma and less than 15 if he has got moderate glaucoma. So, in this study, at 1 year follow-up with 2 iStents, IOP of less than 18 could only be achieved in 9% of patients. And in the hydrous implant, IOP of less than 18 could only be achieved in 30% of patients. And if you see the Kaplan-Meier curve, it is decreasing over time. So the success rate of any MIGS procedure goes down over time due to trabecular fibrosis. So the first take-home message is that whenever you use these stents for IOP lowering, they are not going to achieve target IOP in glaucoma patients. You will still require the patient to continue medication because IOP lowering efficacy is very less. And that is why trabeculectomy still remains the gold standard, because if you want an IOP lowering of less than 18, so you can see even nearly at 10 years, 75% of patients achieve IOP of less than 18. And if you see the iStent, it was only 9%. So if you want a target IOP long term for a patient with glaucoma, there is no substitute for trabeculectomy with mitomycin C. Now, what about we have this very interesting intraoperative angiography system where you can do aqueous angiography. So you put in the eye stents and then you inject indocyanine or trypan blue dye, and you can see how the outflow channels are picking up. And what we found was that after you have put the eye stent, one of the eye stents is draining, the second one is not draining. So actually with aqueous angiography, we will be able to see what is the functional outcome of these devices. So even though they look anatomically very well placed, but they may not be actually draining the aqueous out because there is no collector channel adjacent to the device. So this is very important that you can assess the functional outflow of the eye stent with aqueous angiography. And even though it is looking correctly placed, it may not be draining aqueous. The new stent which is being launched in India is the hydrous intraclavicular stent. So here the basic principle is to have this metallic implant inside the TM. So it will dilate up to 3 clock hours of the canal of Schlemm and facilitate increased aqueous outflow. So this is the hydrous intraclinical stent being implanted under gonioscopic guidance. And this is the very important trial which outlines the 5-year outcomes of the hydrous implant, which is known as the Schlemm's canal microstent. And you can see this was a comparison between phaco alone as compared to phaco with iStent. And you can see at 5 years, the difference between the phaco as compared to phaco with hydrous was only 0.4 millimeter difference in the intraocular pressure. So this is roughly, with hydrous, you got additional 2.3% lowering of intraocular pressure. So the long-term outcomes of the stent is quite less. They are not going to achieve target IOP. And although a lot of implants are being used, the target IOP reduction and absolute IOP reduction is very less in terms of long-term glaucoma management. So what is the take-home message on the MIGS devices? So this is a very important report, the American Academy report, which outlines that the trabecular IMIGS, especially the iStent, Hydrus, and KDV they reported, the reduction in IOP is only 4 to 9%. So this is the most important take-home message, that when you're using a trabecular MIGS procedure, iStent Hydrus or the KDP, it will only provide additional 3.8 to 8.9% IOP reduction. And the very impressive IOP reduction being reported in literature is due to the cataract surgery. So the cataract surgery alone reduces IOP by 21 to 28%, and the contribution of these implants is very minimal. But because the FDA approved these implants in conjunction with cataract surgery, so that is why the IOP outcomes are being reported in the range of 20 to 30%. But that is due to the effect of cataract surgery over 2 years and not due to the implant. I am again emphasizing IOP reduction is only 3.8 to 8.9%, and the amount of medication reduced by these stents is only 0.4. So what in India, what should we be doing as MIGA, which is cost effective, because these implants are so expensive and IOP reduction is very less. So the first thing all postgraduates should learn is to do the goniotomy with a 26 gauge needle. So here you bend the needle and then you strip off the trabecular meshwork. So this is bent ab internogoniectomy. So you just have to know the anatomical landmarks, focus on the trabecular meshwork, and then strip the trabecular meshwork 60 to 90 degrees. So this is a simple procedure which anybody can do and learn, and as effective as any eye stent or hydrus. Now we modified this surgery to make it safer. So what we did was we used a 30 gauge needle because that approximates the diameter of the canal. A 26 is very large and it can damage the adjacent structures. Then we use a viscoelastic to first make a nick and dilate the canal, and then only you rip the canal. So advantage of this is, firstly, you are dilating the canal to restore physiological function. Secondly, you protect the outer wall of the canal because the canal is ballooned. And thirdly, if there is bleeding, the viscoelastic will tamponade the bleed, and you can continue without any obstruction in visualization. So the difference is 30 gauge needle, you make an initial puncture and first you inject viscoelastic and then you proceed to cut the canal. So that is the minor difference, where you can also protect the canal and you can do on both sides to achieve 90 to 120 degree cut of the canal. I believe 90 degree is sufficient for achieving IOP lowering. Now, if you have cases which have got a moderate glaucoma, or you have cases where there is very high IOP and the trabecular meshwork has got debris accumulation like pseudoexfoliation or pigment dispersion syndrome or TM abnormalities like as ceroid glaucoma or juvenile glaucoma, then you should proceed with the MIGS, which is called as the GAT procedure, gonioscopic assisted transluminal trabeculotomy. So this is very useful in patients who have got high IOP with mild to moderate degree of glaucomatous optic neuropathy. And if you compare the GAT with the bang procedure, the success outcome of GAT is much higher as compared to bang. So this is a procedure once patients have got moderate or advanced glaucoma. So you use a 5O Prolene suture. We use a cautery to make the tip of the suture slightly blunt. So first you inject viscoelastic, you tilt the microscope, you will focus on the trabecular meshwork, and then you make a cut in the anterior part of the trabecular meshwork. So this is a cautery. You have to blunt slightly the suture, otherwise it can cut through the tissues. So after the initial goniotomy has been made, so a small nick you make in the anterior part of the TM, and that you do a posterior movement to expose a cavity so that the suture can be introduced. And this is all done under viscoelastic. So you grasp the suture and then it is threaded into the canal. Now it is very important that you at least see that suture going 2 to 3 clock hours, because many times it can go into the wrong location and you will not know about it. The second thing is you should measure the limbus and only use that much suture that will prevent over cannulation. So once the suture goes the entire 360 degree, you will see it coming from the opposite side. And you can see the suture has come. So you grasp the other end of the suture and then you just pull one of the ends to do a 360-degree trabeculotomy. So this is something which all residents should learn and should be taught. And of course, you have thripped, so there is going to be bleed. So you have to do irrigation aspiration and take off the bleed after surgery. And why I said, like, again, you can see the TM very nicely visible. You make a cut in the anterior part of the TM. You introduce the suture, you have got a bulbous tip. And why I told you that you measure the circumference, don't put a very large suture, because here what happened, you can see the suture is going. And now you can see the other end of the suture. So the entire suture has gone, but you don't see the other end. That means it is going in a wrong direction. So now the other end I am introducing on the other side. And now it will come here. So again, the message is that only use the length of the suture which approximates the limbus. So other end has now come, you pull it and now you do a 360-degree trabeculotomy. Now, the major complication that I've seen residents and myself also initially, that you keep on passing the suture, the view is not clear. So the suture goes on very easily, but it is going not in the Schlemm's canal, it is going through the iris in the ciliary sulcus. So if you are not visualizing the suture, it can go into the supraciliary place and cause many complications. So be careful of this. A very important thing is that when you do the ASOCT, you will see this very nice cleft visible in the angle. That is your suture goniotomy. But this can lead to post-operative synechia formation. So you can see this patient was dilated in the post-operative and the iris has got stuck in the GAT cleft. So all patients of this procedure, you must do post-operative pilocarpine for 6 weeks. And this is one of the patient where it was dilated, and you will see that there was periphanteal synechia. It has all gone into the cleft of the GAT. So remember, post-operative pilocarpine is must after MIGS like GAD. Otherwise, you can get synechia and your open angle can get converted into angle closure. So that is a must. Patient has to have head end elevated for at least 2 weeks, must stop anticoagulation, and you warn the patient against any heavy exercises of Valsalva for the first 2 weeks. Very important is to have this reverse Redenberg position when doing these MIGS surgery so that the blood flow drains and the Schlemm's canal is not congested to reduce rates of hyphema. You must use a high viscosity viscoelastic and have the patient to have all precaution for the first 2 weeks. So this head and elevated posture must be there for at least 2 weeks after surgery. So finally, what MIGS is best for our country? So this is a gradation of the IOP lowering outcome. FACO alone, followed by iStent Hydrus, followed by GAD, BANG, or KDB. And the best is, of course, GAD. This is the meta-analysis published in the American Journal of Ophthalmology. So IOP lowering efficacy is best with FACO GAD, followed by FACO KDB, Microhook, or BANG, and lowest with FACO, iStent, and Hydrus. The only issue is that the GAD procedure, because it's 360, has got the highest hyphema rates. So that needs to be warned to the patient. To summarize, if patient has just ocular hypertension without glaucoma, you can implant any stent. Once patient has got a visual field defect requiring IOP less than 18, you need to use a limited trabecular disruption. It can be BANG, microhook, hemigat, or a KDB. Once the patient has moderate to advanced glaucoma or any form of glaucoma where the TM is at fault, then you have to do a 360-degree GAT procedure. This is also now the procedure of choice for primary congenital glaucoma as well as juvenile glaucoma. Once you have a patient who has got less than 10-degree visual field or advanced glaucoma, there is no substitute for trabeculectomy with mitomycin C. The last word about MIGS in chronic ACG. Here you can do a trabecular MIGS, but before that you have to do this procedure. This is called goniospheniculisis. So in PSCG you have synechia. So first you have to open the canal and visualize the TM, and only then you can do any MIGS procedure. So this is a goniospheniculisis being done, and this will be followed by a micro hook. So then you are cutting the TM. So this is called phaco plus goniospheniculisis plus any MIGS procedure. And a word of caution, like in trabeculectomy, we use mitomycin C to prevent fibrosis, but in MIGS, there is no anti-fibrotic available. So whatever MIGS you do, there is going to be wound healing and a rebound increase in IOP. So after 2 to 3 years, whatever MIGS you use, you warn the patient that the IOP can climb up due to the fibrosis occurring in the trabecular meshwork, and subsequently you may have to do a filtering surgery. So for India, I think the best MIGS option, which is cost effective, is to use a 26 or a 30 gauge needle or a 50 Prolene suture. So that is very good for IOP reduction. That must be taught in all training programs. No need for putting any expensive eye stent or hydrus or any other procedure is required. So remember that there is a disparity between what MIGS is being done and what is the quality of evidence in literature about the efficacy of MIGS. So to start with, the take-home message is, if you have early glaucoma, please do 30 gauge or 26 gauge needle bang procedure with viscoelastic. But most important, first you have to done gonioscopy to identify the trabecular meshwork. That is the first step toward doing MIGS. So thank you very much for your kind attention. Jai Hind.
Thank
Tanuj,
you
can
so
I
much,
ask
sir.
one question?
Yes, sir,
Thank you.
sure.
Thank you so much, sir. Yes, yes.
Sure.
Dr. Manoj,
So
sir.
I was thinking,
Dr. Kamal.
yes, I just wanted to know what is the comparative comparison with this organ laser trabeculoplasty and selective laser trabeculoplasty.
Sir, actually, laser trabeculostomy we are not using now, but the SLT now for a patient newly diagnosed glaucoma, SLT is giving very good outcomes. And now
Okay.
there is a non-contact SLT known as direct SLT or the Voyager machine. So it is like a
Yeah.
NCT. So that is giving very good IOP outcomes, and that is now the recommended primary procedure for patients who are newly diagnosed with glaucoma. So it has actually got better IOP lowering efficacy than any of the trabecular MIGS procedures.
Okay. Thank you. Thank you so much.
Thank you so much, sir. That was really a very wonderful talk, and we learned so much. And we have been learning each and every day from you,
Thank
sir.
you.
I have this question that if we don't have any restraint of any financial restraint, which MIGS device will you go, and for which type of glaucoma, depending on severity of glaucoma?
See, if you see the trabecular cutting, so if you are experienced, it doesn't matter, you can use anything. But if you are starting surgery, the easiest cutting device is either the micro hook or the KDB. Advantage of micro hook is that you can reuse for any procedures. Same with the 26 gauge needle. KDB, the cutting of the TM is very easy. So that is a
Right.
good procedure to start with. But once you get moderate or slightly advanced glaucoma, then it is better to do a 360-degree Prolene suture GAT procedure. That will give the best long-term IOP outcomes.
Right, sir. Sir, which instrument we're using to do the goniosynostosis?
So actually, you can do with a blunt chopper, but this is a specially designed GSL hook.
Okay,
But you can do either with a viscoelastic cannula or with a blunt chopper.
right, sir. And to nick the trabecular meshwork before we cannulate it with the thread, which is the best 30 gauge needle, sir, you were using to nick the trabecular meshwork?
No, that is just MVR blade. What we use for side port of the
Yeah, yes, sir.
that you can use, and you can also use any needle you have, like a 24 gauge needle you can use. But because mostly we are doing with phaco, so the same MVR we use for side port, we use to make the initial cut. So that should be about 1 clock hour.
Okay, sir. Thank you, sir.
Can I ask one question to sir?
Sure, sure.
Yeah. So this is Dr. Tirupati, sir. So I just wanted to know that I had been using 26 gauge needle since a long time for doing the bang surgery. What is the length that you recommend, length of the needle that you recommend for doing this procedure, either using a 26 or a 30 gauge needle? The length of the needle, because it gets kinked. If we take a long needle, it's very frequently gets kinked into the eye, and we are not very, the needle doesn't remain stout when we do the procedure.
Yeah, you are you are very right actually. Uh, so 26 gauge needle, it is more robust, and I think for beginners you should start with 26, and the bend should be very less because you just want to incise. The only precaution I would suggest is you have to put viscoelastic in the syringe. So when you make the first nick, you inject some viscoelastic into the canal. So that will help to tamponade bleed and also dilate the canal. So that will make your procedure easy. Why I said you use 30 gauge, because when we did the study on the size of the TM, so actually the 26 gauge is much larger as compared to the diameter of the TM. So when you cut the TM, you are also destroying some adjacent structure. So when you use 30 gauge needle, that is just approximating the size of the TM, so the injury is less. Now, sometimes the only problem comes with 30 gauge needle, that if the limbus is slightly stretched, like in JOAG, it may not reach from the corneal incision to this length of the TM. So there, 26 gauge needle is the one to use. But I think with experience, like we have been using 30 gauge with viscoelastic, that works well. But if you have a micro hook or a KDB, any of these can be used to cut the canal. But remember to follow up these patients over 2 to 3 years, because there is trabecular fibrosis and they can be rebound increase in IOP after 2 to 3 years.
Okay, sir. So the length of the needle that you recommend is 1 inch needle?
We have been using 1 inch needle only, the regular 26 gauge, which is available in the operation theater.
Okay, sir. Thank you. And sir, one more thing, that when we cauterize the suture head while doing the GAT, so what is the end point of making that knob at the end of the suture?
So actually, you have to just have a visual impression. It should be like 1.5 times the length of the suture. It becomes double or more, then you will get stuck in the canal. So it should not be very bulbous suture. So just 1.5 times the length of the original suture. The basic purpose is to just blunt it so that the sharp end doesn't cut through the iris. But it should not be a big bulb.
Okay. Thank you, sir.
Most welcome.
Thank you so much, sir, for a wonderful presentation and practical tips. And moving ahead, we should start the mentor-mentee session. For this, I'll request.
Dr. Ruchika, should we click a photograph?
Yeah, sure, ma'am. Let me.
I will request everybody to switch on their cameras. Dr. Ruchika, you can click.
I think it's the button is not working. I'm using someone else's laptop.
Okay,
Let me.
no problem. I will do it. Okay, thank you. Sir, just
Thank you, ma'am.
one last question, sir. Which is the best gonio lens, the direct gonio lens for use intraoperatively?
Actually, in RPC, we have been using a Swan Jacob gonio lens.
Yes, sir.
But I would recommend you, if your residents want to do from tomorrow, you try to just tilt the lens, put in BSS, and see the gonioscope just with water gonioscopy. So you can have very good training with that.
Sir, with Sean Jacob, sometimes like when it is being held, so while holding, sometimes one hand is stuck, so you cannot do maneuvers from both the hands.
Yeah, so actually there are now a lot of gonio lenses available, and there's also a gonio ready and hands-free lenses which can be attached to the microscope.
Okay, sir.
but they're all like pretty 60-70,000 to 1 lakh per lens. You
Right,
also have
sir.
disposable lenses available which
Yes.
you are reusing, but in RPC we only had Swan Jacob, so I only have experience with that.
Disposable, sir, I have used, but only thing is that once you use, then it becomes useless. So it is in government setup, it becomes a bit costly affair.
Yes, yes,
So go. Otherwise, they are very good disposable one. The
yes.
clarity is also extremely good. Thank you,
Most
sir. Thank you so much.
Okay,
most
okay.
of us are using Katina and eye prisms also, and the
Mm.
one with the metal handle, the Vogue lens, that is also very good, which is actually autoclavable.
And
Yeah.
there is one more lens from Dr. Mori from Japan. So there they don't require the patient head to be tilted. So that is another advantage.
But
Right.
that the view of the angle is very less in Mori's lens, no? Only 30 degrees.
Mm. Okay.
Thank you, sir.
Okay.
Thank you so much. So moving ahead to the mentor-mentee session. For the first case presentation, I invite Dr. Geeta Behra. She is an additional professor at JIPMER Pondicherry, and we look forward to her valuable insight in the case presentation by Dr. Sahila. Dr. Sahila, can you please share your screen?
Yes, I'm sure. Shall I start, ma'am?
Yes, yes, please.
Good evening, all. Myself, Sahila, junior resident from JIPMER. I'll be presenting an interesting case of partial sclerocornea with cornea plana and cataracta nigra. We had a patient of 42-year-old male, farmer by occupation, hailing from Tamil Nadu, who presented with complaints of diminution of vision in both eyes since 1 year. Coming to the presenting illness, history of poor vision since birth, followed by gradual worsening of vision in both eye over 1 year. There was history of similar complaints in sister and paternal uncle. No other significant history was noted. This is a pedigree analysis of the patient showing the same. The arrow showing the index case and the shaded showing the affected paternal uncle and the sister. Coming on to the general examination, patient had short stature, short stubby fingers and low set ear, and rest are unremarkable. Systemic examination was with a normal limit. Coming on to ocular examination, head posture was erect, facial symmetry was maintained, eyeball position was orthotropic, extraocular movement was full and free. Eyelid, patient had both a downward slanting of palpebral fissure. Coming to the right eye examination, visual acuity in the right eye was hand movement close to face with a projection of rays accurate. Ocular adnexa were normal. Patient had a horizontally oval flat cornea which was measuring around 8 cross 9 mm diameter. The limbus was enlarged and ill-defined, and there was absent lucid interval. And the peripheral cornea achieved the sclerization or scleral characteristics. There was a peripheral corneal opacity with vascularization. Similar findings were noted in left eye. Remaining anterior segment examination was unremarkable. This shows the slit-lamp image of the anterior segment, which shows ill-defined limbus with absent lucid interval, with a peripheral corneal opacity and slit-like pupil. On posterior segment examination, the posterior segment view was poor. There was no view because of the poor mydriasis. Summary: 42-year-old male with no known comorbidities came with complaints of poor vision since birth, followed by gradual worsening of vision in both eye over 1 year. On examination, both eye visual acuity was hand movement close to face with the projection of rays accurate. IOP was 11 mm HG with a non-contact tonometer. He had both eye small, flat, horizontally oval cornea with corneal diameter around 9 cross 8 mm with ill-defined limbus, absent lucid interval, and there was peripheral corneal opacity with a superficial vascularization. So we made a provisional diagnosis of partial sclerocornea with pupillary phimosis. Since there was no view in posterior segment, we did B scan, which showed both a retina on and vitreous anechoic. To know the anterior chamber extent, we did anterior segment OCT, and to see the anterior segment structures also. And the manual axial length was measured, which showed right eye 28.45 mm, left eye 28.02 mm, which was showing the axial myopia. This is the topography of the patient, which confirms the cornea plana. So our final diagnosis was partial sclerocornea with cornea plana and pupillary phimosis. We approached this case through a staged surgical procedure. First, patient underwent left eye sphincterotomy. Intraoperatively, it revealed black cataract. 2 days later, we took the patient for right eye sphincterotomy plus the extracapsular cataract extraction through a short scleral tunnel with posterior chamber IOL. Since the patient had fair amount of visual recovery, 2 weeks later, patient underwent left eye extracapsular cataract extraction plus posterior chamber IOL. These are the glimpse of our surgery. We made a 12 scleral incision and we made a short scleral tunnel. Sclera was too thin to perform SICS. We entered into the anterior chamber. While entering to the anterior chamber, it is visible that the anterior chamber was extending more posterior to the posterior than expected apparent limbus. And we had to use endo-illuminator to visualize the anterior lens capsule before doing canopner capsulotomy. Since central cornea has slightly hazy and because of the black cataract also. This image was taken post-op day after 1 week. Right eye visual acuity was 624. Left eye also had similar visual acuity of 624. The visual recovery was suboptimal because of the pathological myopia. So challenges in our cases are pupillary phimosis was there, which was obscuring the assessment of posterior segment. And the patient had both cornea plana and axial myopia. So we had to use multiple IOL formulas to calculate the IOL power. And there was a sclerization of the peripheral cornea. So exact extent of the anterior chamber to make out the anterior chamber extent, it was difficult. So we had to do anterior segment OCT and the UBM. And there was a corneal haze. So to visualize the capsule during the capsular excess, we had to use the help of endo-illuminator. Thank you.
Yes, thank you. Thank you, Dr. Sahila. And I'd like to request our mentor, Dr. Geeta, to please share your views on this.
Oh, I welcome comments from others as well, because as is clear, this was a problematic case. We have, though we do see many cases of, we do see the occasional sclerocornea, but a partial sclerocornea with a pupillary phimosis, that was extremely unusual. So that was off a little, because behind the phimosis, the lens status was not known at all. There was no way, they had no view. So we decided to explore and do what you call it, we just did a pupilloplastic just to see how much, what is there behind, and we were shocked to see that there was a black cataract. And since we had only planned at that point of time for the pupilloplasty, we did not proceed with the cataract surgery for the first time, and we deferred it by 3 weeks because by 2 weeks because we wanted to give a bit of a gap between the first and second surgery. So, but in order to give some vision, because the patient had barely finger counting and hand movement vision, so we proceeded with the same procedure with cataract removal in the other eye first. And then 2 weeks later, when we saw that the patient was doing well, we did this eye. So the challenges here were, of course, several, because there were several challenges with the decision making, because we were not certain what we were dealing with. And of course, IOL power calculation, again, we did using the online formulas, the latest in the Himalaya. And we also had to order the list especially for the patient in this situation. And we also had the problem of what we call the poor visual prognosis due to the high myopia. So we also explained to the patient that the high myopia, it is pathological myopia, is going to pose a problem, and so we do not know how much we have reported. So I welcome comments for Saila and me. Saila, I would like you to unmute yourself and also your video and it's on the video.
Good evening. This is Dr. Abjeet from Lucknow.
Good evening, ma'am.
Congratulations on the wonderful presentation and the handling this difficult case.
Thank you,
I
ma'am.
have two questions. I'm basically an oculoplasty surgeon.
Yes,
So
ma'am.
I have two questions. First is that when you did the B scan,
Yes, ma'am.
at that stage, the cataract was not evident?
The cataract was when you we did UBM and ASOCT both to see whether the lens was in its position and not dislodged. So the ASOCT did not really help us because the was very opaque. We did a UBM as well. Now we haven't really shown those
But I'm
pictures.
surprised that the ecogenicity of the lens was not picked up on a B scan. That was one question. The second question is that post-operatively, did you do an OCT macula? Because 624 vision, okay, there has been a corneal opacity, central corneal opacity that could contribute to that. But it would be worthwhile looking at it that with a large axial length, what was the health of the macula?
Yes, ma'am, it was done. And I think, Saila, do we have those? It was done. I'm not showing everything here
No,
because
no.
we
My
plan.
question is, I was just trying to figure out what
Yeah.
could be the reasons for the 624 post-operative vision.
Yeah, foveal thinning most likely due to the
Yeah,
pathological
yeah,
myopia.
exactly,
Yeah,
exactly.
yeah,
Thank you so
yeah.
much.
Could
Yes,
be
ma'am.
anisometropic amblyopia can cause the blur vision.
That was extremely wonderful presentation, and I congratulate both Sela and Dr. Geeta for this amazing showcase of this wonderful case. So I was just wondering, what would you suggest for IL power calculations? Like, how should one go for keratometry, and what axial length? So, any particular precaution you took for doing keratometry in this patient?
So we have a topographer, so we just the topographer.
So you
Yeah,
did topography.
yeah,
Like
we just
sometimes people take iron master
mm,
readings.
yeah.
So
We
you
are
prefer
yeah, we prefer the topography over the
and
IOL master, yeah, in this particular situation. Yeah. And the A
and
scan, of course, had to be repeated a couple of times. Immersion, A
yeah,
scan, manual, everything. You had to repeat a couple of times. Yeah,
because
and
generally optical bimeter cannot take reading in these
yes,
cases.
absolutely. Because it was a black cataract, there was no chance of getting an optical binder.
Yeah.
So it had to be repeated a few times and confirmed. It was done by one of our expert optometrists and we confirmed it. And yes, as Dr. Abhijit was asking, we did pick up the echogenicity, but
Yeah.
the lens is there, that's cataractous, but then we really didn't know what's happening because there was no direct view. So, we didn't
Right.
want to go in blind and just make a mess because we wanted to give vision to the patient at the end of the day. So
Very true. Very nicely managed. Yes.
thank you, Dr. Shalini. Thank you for the invite as well. Yes,
Yes,
ma'am.
ma'am, because
Nicely done surgery. I just
Thank you,
want to
sir.
ask one.
Yes, sir.
Since the chamber was very shallow,
Yes.
so did you check after the surgery what was the health of endothelium? Like
The
pre and
chamber was, yes, the chamber was not very shallow. Chamber was, yeah, relatively shallow, but not very shallow. Yeah, and the endothelium, yes, we did check, we did. Yeah, it was, again, the specular was not what you call so easy to capture, but we did manage to capture because these retinal photographs that you're seeing on pass shows actually a clear cornea. Actually, it wasn't that way. The central cornea was also slight hazy. So hazy that
yeah,
it was not possible to execute a good capsular opening as well. I had to take the assistance of an endo illuminator and do it. But the endothelium, yeah, whatever we could make out seemed all right, yeah. And the anterior chamber actually was extending well beyond the anterior limbus. It was actually quite posterior. So the EC count is probably higher because endothelium is probably more than what we are seeing. So the EC count, the probably patient has more endothelial cells than we are able to capture on our
thank you.
assessment there.
Thank you.
Congratulations, Dr. Geeta. It was a very difficult case and very well managed. I have two questions. Which formula online did you use for ILPA calculation?
Yeah, Sahila, will you please answer that question?
Pardon?
I'm asking Sahila to answer that question.
Okay,
Okay.
okay, great. Yes, Dr. Sahila.
We had used multiple formulas, ma'am, AI generated, and Hill RBF also we tried, ma'am.
Okay, so you chose the result from the Hill RBF formula.
We did multiple, and then we just made an assessment of what would match best given the cornea plana and the myopia. And yeah, we made we made an assessment based mostly on the Hill RBF, but we did calculate using multiple formulas, and then we took a call.
Okay, okay. One more question. I saw you made a particularly large incision. So would you like to explain your choice of incision? And secondly, where exactly did you make the entry?
Yeah. So as you can see, one was that there was no a proper landmark on where the anterior chamber ends and where actually the sclera begins, because anteriorly there is sclera, but posteriorly it is actually the corneal endothelium. So I went almost 3 mm, 3 or 4 millimeters posterior to the apparent anterior limbus. And when I started started doing the dissection, the idea was to thin it sufficiently so I can make out where I should even enter. So yeah, so that was the idea. That is the reason why you see I have made a very large semicircular incision around, dissected all around just to make out, because once we go partial thickness into the sclera, we get a better idea of where the posterior limbus is ending. And because the nucleus is huge, it was a big, huge black nucleus. So I didn't want to try anything even remotely risky. So it was actually a ECC. Yeah, it was a ECC IOL, and it was so it was the ECC IOL. There's just that it was modified for the sclerocornea that we are seeing. That's all. And just to know where is the posterior extent of the limbus. So, and like an ECC IOL, I made an institution along that. And,
Okay, thank you, Dr.
yeah.
Geeta.
आज से 2 महीने रह गए आपके
Thank you, ma'am.
Thank you, Dr. Geeta, Dr. Saila.
Thank
you so much for
Geeta.
wonderfully managing the case and sharing it with us.
Thank you so
Moving
much.
forward, I'd like to invite Dr. Devang. She's additional professor, AIMS, New Delhi, to enlighten us. And for this, for the mentee, I request Dr. Avneet Kaur to please present her case. Dr. Avneet, yes. Avneet?
Good evening, everyone.
Yeah, good evening.
I'm going to present my case on late onset post-AGV hypotony under the guidance of Dr. Devang Hango. A 30-year-old male patient presented to our center, which was an outside diagnosed case of primary angle closure glaucoma with diminution of vision in right eye for 15 days, which was associated with watering, redness, and pain. There was no history of trauma. So his previous surgical history was as follows. He was operated both eye Ahmed glaucoma valve implantation. Left eye cataract surgery had been done in 2019 and left eye OPK had been done in 2020. On examination, um, his visual acuity in right eye was hand movement close to face. PR was accurate in the right eye, and IOP on non-contact tonometry was 4 millimeters of mercury. In the left eye, his visual acuity was hand movement close to face, but PR was accurate with an intraocular pressure of 26 millimeters of mercury. Left eye AGV plate was in situ, but the graph clarity was 0 in the left eye, so no other details were visible. For the right eye, AC was shallow. We could see the AGV tube, which was inside the anterior chamber, which was touching the cornea, and there was a posterior subcapsular cataract. ASOCT was done for the patient, which revealed that the AC was shallow and the tube was touching the cornea. Posterior segment evaluation showed that the patient had a total cupping with macular striae, choroidal folds, peripheral CD mounts, which was suggestive of hypotonic maculopathy. This was the biometry done for the patient. This is the ultrasound photo for the patient, which showed choroidal mounts, and the optos also showed peripheral CD mounts for the patient. UBM was done for the patient to rule out any ciliary causes of hypotony. So, on the basis of history and investigations, the patient was diagnosed as both a juvenile open angle glaucoma, right eye late onset post AGV hypotony with hypotonic maculopathy with posterior subcapsular cataract, left eye failed OPK with AGV in situ. So the patient was first medically managed on oral steroids. Right eye was we had topical steroids were started for the right eye also, which included difluprednate 6 times a day, and atropine ointment was started for the right eye. AGMs were continued for the left eye. Patient was kept on medical management for 4 weeks with no resolution of hypotony, and then was planned for right eye phacoemulsification with posterior chamber intraocular lens with Dhelon and AC. Intraoperatively, direct gonioscopy was also done for the patient, which showed no cyclodialysis cleft. After the surgery, post-operatively, visual acuity at 1 week was 1/60. Intraocular pressure was 6 millimeters of mercury. The vision for the patient, best corrected visual acuity for the patient improved to 6/36 at the end of 2 months, and intraocular pressure also rose to 12 millimeters of mercury at the end of 2 months. So this is the anterior segment clinical picture post-operatively, and this is the ultrasound and the opto-CP for the patient at 2 weeks. Post-operatively at 1 month, best corrected visual acuity in the right eye was 636 and near vision N10. IOP in the right eye was 11 millimeters of mercury. At 6 months post-op, patient again presented to us with diminution of vision in the right eye after being lost to follow-up. On examination, visual acuity had again fallen to hand movement close to face. PR was accurate. Intraocular pressure was 6 millimeters of mercury. Posterior segment showed choroidal mounts and hypotonic maculopathy. So patient was planned for right eye AGV tube stenting with 30 Prolene. The post-operative picture is as shown in the slide. Post-operatively, on day 1, IOP was 14 millimeters mercury for the patient, and it was maintained till post-operative day 7 at 11 millimeters of mercury, and choroidal mount showed slow resolution. At 1 month, the patient again had choroidal mounts, and IOP again fell to 3 millimeters of mercury after tube stenting. So the patient was then planned for right eye AGV tube exteriorization. These are the post-op pictures for the patient. On post-op day 1, patient had an intraocular pressure of 12 millimeters of mercury and vision was hand movement close to face, PR accurate. IOP stabilized for the patient and then showed an increasing trend for which topical anti-glaucoma medication had to be started. At post-op month 3, patient is maintaining an intraocular pressure of 13 millimeters of mercury on 1 anti-glaucoma medication. So there were multiple interventions that were done for this patient. First, we tried to manage the patient on medical management. Phacoemulsification was done for the patient, followed by tube stenting, and then followed by tube exteriorization. So advantages of tube exteriorization over explantation are that it is minimally invasive and it is reversible. The take-home message from this case was, although the surgical techniques like OVD injections, tube stenting might effectively control post-op hypotony, but multiple revisions might be required. Hypotony following glaucoma drainage device implantation is difficult to manage, requires long-term follow-up, and can result in permanent vision loss. But if managed promptly and appropriately, patient's vision can be saved. Thank you.
Thank you, Dr. Avneet. The case well managed and the vision saved. Requesting our chairpersons, Dr. Tirupati sir, you want to?
Yeah. So very nicely managed, a very complicated case. I just have one question in mind, that what was the possible cause of hypotony in this patient? What was the cause in mind?
Avneet, I think you have made a slide also on causes of late onset. Can you just enumerate those causes? Okay, so basically when we, I think
Yes.
Avneet, Yeah, you are there. Yeah, you can.
Yes, ma'am. Ma'am, so the causes of late onset AGV hypotony could be insufficient end plate encapsulation, reduced production of aqueous humor secondary to postoperative inflammation, iatrogenic cyclodialysis cleft formation, ciliary body atrophy, peritubular filtration, or faulty valve mechanism.
So almost all the things I think were ruled out except
Yeah.
for the faulty valve mechanism, I think.
Yeah,
Rest
so
everything was
that is what we the at the end what we have basically what we have to look is that why is the valve, why is the hypotony after such a long, I think 6 or 7 years. So after ruling out everything, we had come to a diagnosis that it probably is a faulty valve mechanism. And when the patient has is having multiple interventions, he is also not willing to get the AGV explanted in the first go. So that's why we had to externalize the tube and see how the this thing is performing. And after externalization, we realized that actually the valve was faulty, and that's why the pressure started rising once we externalized the valve.
Yeah. So how do we go ahead in such patients if the pressure keeps on rising now?
So till 6 months of follow-up, he is on combination medication. He's on one combination medication. So we are keeping our fingers crossed. So we'll step up the medications. That is what it is, because before was doing all these interventions, we always give a trial of steroid. These patients who respond to the steroid, we don't usually intervene because we know that the pressures will rise. And this was like a very difficult case wherein it was very difficult to make the pressures, build
Yes,
up the pressures.
yes. So
So we are keeping our fingers crossed. So till six
actually, it was a
months.
very wonderfully managed thing.
Thank
Wonderfully
you,
managed.
Dr. Tirupati.
And one more input that I would like to give is that after listening to Sir's talk, Tanuj Sir's talk, maybe even if we have a failed AGV or a failed valve in these patients, we can give a try to mini GAT or a GAT in these patients. The pressure goes high again.
See, definitely, anything can be done to control the pressure. So post-rab that we are doing, we have been doing a couple of patients. I mean, and now we have more than I think 30 patients where we have done post-rab, and they are doing well.
Yes, yes.
So there are multiple this thing. Anything can be tried for the patient, and if you can see the angle is open, so we can also give a trial of SLT if the pressures is rising. So I mean, there are multiple options if the pressures rise.
Acha, what is do we have any time encountered a patient who has been continuously rubbing the eyes? These GOG patients, sometimes they have allergic conjunctivitis, also very commonly seen. So, does the rubbing of the eyes frequently over the valve area, does it causes the damage to the valvular mechanism? Has there been any reports regarding that?
I'm not sure about valvular mechanism, like because the valve basically is at the it's around 10 mm away from the limbus, right?
Yes,
And
yes, yes.
rubbing is usually at the limbus, if you see.
It can cause erosion to the tube, but
Yeah, most common that we've seen is, especially in young adults or kids, there is tube erosion
tube
or
erosion.
tube extrusion. That's the most common thing, and endothelial damage.
And that was actually ruled out in this patient.
Yeah, this was ruled out. And when we externalize the tube, we also ruled out peritubular leak. And peritubular leak, usually, if it is there, it should be present in early,
Yes,
post-op,
yes,
which was not there in the patient.
yes, yes, yes. So congratulations again for wonderfully managing this young chap.
Congratulations, Dr. Devang. That was a very nicely managed case. And congratulations to your mentee also for wonderful mentor also for wonderful presentation. Acha, I was just wondering, can we try any MIGS in this subset of patient where if pressure starts rising? Have you ever tried
Yes, that's what I was.
supplementing these patients?
Yeah, that's what I was. We were discussing with Dr. Tirupati that, post all these failed surgeries, because MIJS was not there, and especially the pediatric cases that we are following up. They are like now 20 plus years, 30 plus years, twice or thrice operated trap with a valve. We have given a trial of MIGS in them. So, I mean, the long-term data, as Professor Dada has mentioned, so we have like 2 or 3 years of follow-up. So the trend is that in the first 2 years, the pressure control is good, but eventually we have to step up the medications. So till now, I mean, patients is on combination 2 or 3 medications, and it is controlled on on these medications.
So which one do you prefer the most?
So that's what we have been discussing. For advanced cases, I mean, we are doing GAT, 360-degree GAT.
Right. Because of maximum IOP lowering efficacy.
So all these patients that come to us usually is advanced. So we prefer to do which is the best working in these eyes.
Thank you so much. That was wonderful case.
Welcome.
Congratulations, Dr. Devang. Very nicely managed case. I have one question. When there was hypotony, you proceeded for phacoemulsification with viscoelastics. Now, phacoemulsification is known to decrease the IOP further. So, can you just elaborate the
So
concept behind
basically,
phacoemulsification?
so if you look at our case, the patient had come with a shallow anterior chamber with a tube endothelial touch. So we actually had to do something. And what we saw was that there was also a posterior subcapsular cataract. So anyhow, patient had to go cataract surgery. So if you see, and a lot of our this thing is that post cataract surgery there is inflammation that is induced. So this inflammation leads to fibrosis, which eventually leads to rise in pressure. And I think most of our glaucoma consultants would agree that post cataract surgery the pressure rises in these patients.
Yes.
Yes. Okay, so that would have helped in managing the hypotony.
Also, we
Thank you.
had to reform the anterior chamber, which was shallow.
Yes, for sure. Thank
So
you.
one more thing, Dr. Devang, which suture had you used for stenting the tube?
So we usually prefer a thicker suture like 40 or 30 Prolene.
Okay.
Thank you, Dr. Devang, Dr. Avneet, for this wonderful presentation. Moving ahead, we have an excellent mentor, Dr. Professor S.P. Singh from Allahabad. Welcome you, sir. And further, he'll be supervising the
Thank
case
you
by
so
Dr.
much.
Utkarsh. Good evening, sir.
Good evening.
Yes. Dr. Utkarsh, yes, he's there.
Yes. Shall I start, ma'am?
Yes, please go ahead.
Good evening, respected teachers. So I'll be presenting the canalicular laceration repair using the Mini-Minoka stent. So the earliest method of canalicular laceration described the use of malleable rod to assist in repair. Several subsequent methods were developed, but one which found favorable for several decades was the pigtail probe. Then direct anastomosis of the lacerated end of the canalicus was yet another technique. Then came the bicanalular stent, naming the Crawford and then Rittling. Now currently we are using the monocanalular stent, that is Mini-Minoka. What is Mini-Minoka? It was designed by Bay Fennett and J.A. Bernard, and it is indicated for the canalicular laceration involving external two-third of one canaliculus only, and can also be used in the management of epiphora secondary to canalicular stenosis. The advantage is that it doesn't require any suture. Stent is securely anchored at punctum by a fixation head. It is a medical grade silicone and it requires single-use punctum dilator and a plug inserter. So this is the Mini-Minoka stent. This is the circular collarate part, which is seated flushed within the ampler region, and the length is about 40 mm and the external diameter is 0.64 mm. So various clinical indication of Mini-Minoka is that one is of course the canalicular laceration, which was used in our case. Then it can also be used in the punctal and canalicular stenosis. It is utilized during punctalocanaliculoplasty to treat severe narrowing of the tear drainage opening, providing a long-term symptomatic relief from chronic tearing. Also, the tumor excision safeguard, like in oculoplasty, and most surgeons use it to protect and preserve the tear duct framework when removing tumors, especially when the tumor is situated very close to the medial corner of the eye. So coming on to my case, the patient, age 27 years, student by occupation, resident of Prayagraj. Patient, he had complaints of excessive watering, mild bleeding, pain around the eye, difficulty in opening the eye. Patient came to a hospital 2 hours after a blunt trauma to the right eye with a wardrobe hanger. He had pain, mild bleeding with excessive watering from the right eye. He had no complaints of any visual loss as such. On examination of the right and the left eye, everything seems to be within normal limits except for the right eye, which had a cut that was about 2.5 mm medial to the lower punctum. So this is the pre-op image showing the cut at the lower inlet margin. So I would like to show you a short video clip of the surgery. So before the surgery, we gave the patient a drop of tetracaine to achieve conjunctival and ocular surface anesthesia, then cleaned the wound with alcohol prep pad, injected 2% lidocaine with epinephrine for anesthetic and of course the hemostatic effect. With the patient being comfortable, we irrigated the wound. Actually, after the trauma, irrigation of the wound is very necessary, and we prep and drape the patient in a sterile standard fashion. So before starting, yeah. So we use a punctum dilator to enlarge the punctum so that the silicone stent can be subsequently passed through the canalicular system. Then cut the minimonocal stent approximately 10 mm with a bevel edge. Then insert the stent in the punctum and follow the canaliculus. Then retrieve the stent from the proximal end of the canaliculus and pull the stent so that the collar is seated flush with the punctal ampulla. This may require pushing with the second forceps, as can be seen in the video also. So I would stop here. This for the introduction of the distal portion of the stent into the nasal portion of the lacerated canaliculus is the most difficult part of the surgery. The nasal portion of the canaliculus may be identified by directly observing a circular pale appearing canalicular passage or by injecting the opposite puncta with air, with the canaliculus of interest being submerged under saline or clear liquid. Or we can use the help of fluorescein dye or trypan blue also. And thus we can see the bubbling effect or the fluorescent or the injected dye coming out from the lacerated canaliculus. In our case, it was the direct visualization of the nasal or the distal portion of the canaliculus. And we can see how nicely the distal portion is being introduced. So suture the stent in the place by using a 6-0 vacuole suture. The 7-0 polygalactic suture can also be used and has been used by some of the surgeons. This is the horizontal mattress suture. After this, the lid margin was closed with the help of a 506 suture. So this is the post-op image day 1. And so we can see how nicely the lid anatomy has been restored. Then this was just an image taken after 1 month. And this you can see how well the lid margin has been opposed. And also the patient had no complaints of any foreign body sensation or watering. In the first image, in this, you can see that nothing is visible from outside. Only if we just I just show you next photo also. Yeah. So in this, you can see the collar is visible only if we invert the eyelid. So coming on to the advantages of the minimonocal stent, it maintains proper alignment. It prevents any stricture formation after the repair. And since it is an inert and stable material, it minimizes the ocular irritation and tissue trauma also. Unlike traditional bicanalicular stent, it bypasses the need to loop through the nose or touch the opposite uninjured tear duct, eliminating the risk of collateral damage or nasal bleeding. So to conclude, monocanalular intubation is effective and the most common method of treatment for canalicular laceration today. It has several advantages over other previous techniques used, like it maintains proper alignment of the anastomosis and prevents stricture formation, which was seen with direct anastomosis of the canalicular mucosa, and the risk of damaging the uninvolved canaliculus and creating a false passage, as was seen with the pectoral probe. Also, the ease of removal at the slit lamp and no danger of cheese wiring or erosion of the puncta, as occasionally occur with bicanalicular stent. Thank you.
Yeah, thank you, Dr. Utkarsh. A wonderfully managed case. I'd just like to ask if you'd like to give any advice to the patient post-operatively who has this
Yes, ma'am.
stent in situ.
Yes, ma'am. Post-operatively, ma'am, the major advice which you give the patient is that frequent rubbing of the eyelid. He should avoid rubbing as it can cause avulsion of the tube or dislodging also. So we do provide the patient with lubricating for at least 2 to 3 weeks, and after we keep the patient on follow-up, and also prevent the patient from touching his eyes and rubbing, especially the lid which has been sutured.
Right. Requesting our chairpersons. Anyone want to share some insight?
Do I have your permission to make a few comments?
Yeah, sure, ma'am. Please. I was about to, in fact, request you to comment on this something.
No, there's nothing to request.
Right.
I just have a few observations on what has been presented. There was a statement which said that mini Monoca does not cause canalicular stricture.
Yes, ma'am.
Now, canalicular stricture is not the function of your stent. Any material can or cannot lead to a stricture. The formation of the stricture actually is the function of your suturing. It's not the material at all.
Ma'am,
Second thing, whenever you repair a canaliculus, see, mini Monoca has been in use for now more than 2 decades. So it is nothing new. So I was actually wondering, why did you choose to present this case at all? Because there was nothing which was spectacular here. If it's a question of introducing the mini Monoca stent, it is well known. The point that I would like to highlight is that whenever there are lower eyelid medial injuries involving the canaliculus, the first thing that you need to do is to assess the depth of, see, the canaliculus has been cut. That point is well taken. But how deep is the other injury? Because right behind that, a little more medially, is your entire lacrimal system. Also, the edge of your medial canthal tendon is very close to that area. So, all that anatomy needs to be assessed. If you will only focus on threading the canaliculus and think that your repair is adequately done, sooner or later, you will develop deformity in that area, and that is where your stenosis will come in. This stenosis does not occur within the first 3 weeks or 4 weeks. You give this patient a follow up of 6 months, then you will know the actual outcome of your repair. So, while dealing with medial eyelid injuries, the canalicular laceration per se has to be assessed along with the assessment of the deeper tissue injuries. Because, see, your history says that the injury was with a hanger,
wardrobe angle. Yes, ma'am.
wardrobe hanger. It is very strange for a wardrobe hanger, until and unless it has a sharp edge, not to have a crush injury along with it. This must have been some sort of a tear. It must have got entangled and pulled it. Or
Yes, ma'am.
else that hanger must have had a sharp edge. So that is what you need to identify. What was the material and what was the dynamics of the injury? Because if you carefully see your preoperative photograph, there is a very distinct swelling on the medial side of your cut, which is an indicator that there is a crush injury on the medial side. If you go back to that image and revise it, you will notice this feature. So, trauma per se should not be taken very simply and easily. It may look very simple. कि अरे ये तो छोटा सा cut है, हम कुछ कर देंगे. But it is only later that you realize that if your 3D alignment is not correct, then you will land up with problems. And that's my bit to it.
Yes, ma'am.
Hello.
Yes, good evening,
Yes,
sir.
sir.
Okay, good evening. Madam, I already said very rightly, but the question is, from any kind of physical suturing is very three-dimensional suturing is very, very important. But when compared with any other devices, definitely has a lot of advantages. Like you will put this pigtail technique, but the identification is very important. So if you use the pigtail, definitely may damage to the normal canaliculus. So this is the, if you compare with other method, like you can pass the simple tube, cannula, then again you have to require the suturing. Once you require the extra suturing, definitely may cause a further damage to. So it has definitely some advantage that is self-retaining. The colorate is there that is may fix to the this ampulla of the this punctum. So it
So
has
there is
a
no doubt about its
advantage.
advantage. It
Yeah.
definitely has an advantage, but it's been there on the scene for a very long time now.
Oh,
What?
there's no problem. The question is the only comparison of what are the other methods and which is better, has a better result. So this is also a question of discussion that somebody, suppose, hardly makes any difference if the question of only cost of the miniminuka. So if it is not available, then in emergency situation you can use the cannula. Otherwise, what is the
So your voice is
Transmission
breaking.
or the repair is meticulous repair is definitely very, very important in either any method. You are very correct, you have said. The result depends upon the injury, extent of the injury, whether it involves other deeper tissue also. So you have to take care of also the repair, proper repair is very, very important. Thank you so much.
Yes, thank you,
Any other
sir.
question?
Thank you, sir. With this, I think we come to the end of our this mentor-mentee session. And on behalf of UPSOS, I'd like to thank all the chairperson, Dr. Abhijit Kaur ma'am, Dr. Manoj sir, Dr. Shama, Dr. Tirupati, and all the mentors, Dr. Geeta, Dr. Devang, SP Singh sir, for sparing time and just enlightening us with their knowledge. And the special thanks to the mentees as well, Dr. Sahila, Dr. Avneet, and Dr. Utkarsh, who have presented beautifully. And last but not the least, I'd like to thank Dr. Shalini Mohan for organizing this mentors-mentee session on regular intervals. I think she's the torch bearer, motivating us all for these sessions and these kinds of academic activities. So, Dr. Shalini.
Thank you so much, Dr. Ruchika, for moderating it so well. And I am thankful to Dr. Shama, Dr. S.P. Singh sir, and Utkarsh for this wonderful case. And of course, to chairpersons, Dr. Abhijit, for her insights. And we have seen her teaching us from the very beginning since we were JRs. And even now we learned so much from her. Thank you, ma'am. Thank you so much.
My pleasure. Thank you. Gracious of you to use those words.
Thank you, ma'am. And of course, to Dr. Tirupati for his insights on glaucoma cases. And thankfully, we could catch him this time. Otherwise, he is extremely busy. Dr. Tirupati, your insights were really very good, and we are so thankful to you. And thank you, everyone. And I think now we can wind up this session of UPSOS. Good night, everyone.
Thank you, ma'am. Good night.
Thank you, ma'am.
Okay, bye.
Okay.